Thank you for APA team for giving us an opportunity. Actually, Chatur is an MT second year student of Amrita Medical College who had an DRP posting at General Hospital Ernakulam. We are also having DNB academics there, and he came for a DRP posting, and he had a case in November. The case presenting here is a case came to my unit in November, and actually he presented that case in December end or January and asked our Karthik to have an opportunity for him to present here. Okay, all the best wishes. Chatur is a budding physician from Amrita, and give encouragement for him, and thank you all for giving us an opportunity for along with Chatur, our GH team. Okay, thank you.
Thank you, ma'am. Good evening to all the respected members of API present here. So, I'm Dr. Chatur Agnivesh from Amrita Institute of Medical Sciences, and I was posted in GH Ernakulam for 3 months, where I had encountered this case. So, I'll be presenting my case here, the deceit of weakness, where I did get deceived by the case, so hence the title. So, our patient was a 47-year-old male. Carpenter by occupation from Fort Kochi of a upper lower class, and he lived in a pakka house. His chief complaints when he came was fever for 5 days, then loose stools for 2 days, and bilateral lower limb weakness for 2 days. So the patient actually, the presentation started with fever and retroorbital pain and generalized body ache for 5 days on 22nd of December. So this patient had a sudden onset high-grade fever for 5 days that was associated with chills and rigors, no night sweats. The fever occurred intermittently with the peak readings of 1 or 2 degrees, and it was relieved with paracetamol. The patient also gave a history of diarrhea for 2 days. He passed stools 3 times per day at around 6 on Bristol stool chart, and it was watery inconsistency. This was followed by bilateral lower limb weakness that was acute in onset and 3 days after the onset of first episode of fever. The weakness was symmetric, predominantly affecting the lower limbs, and was associated with difficulty standing and walking, primarily said by the patient. He had difficulty getting up from his chair and bed without any support. The patient also had complaints of increased urination and increased thirst for the past 1 year. He did not give any history of cough, sore throat, dysuria, or abdominal pain. There was no recent travel or any contact with sick individuals. There was no history of blood or mucus in the stools. No recent changes to diet or outside food intake. There was no history of difficulty combing his hair with fine movements like buttoning his shirt or tripping while walking. There were no paresthesias experienced by the patient, no history of fecal or urinary incontinence, and no ocular symptoms. He denied any palpitations, tremors, or weight gain or weight loss. And when we went to the drug history, there were no evidence of any statin, diuretics, or laxative use. So initially, he was evaluated in outside hospital, and he was found to be dengue positive on 24th of December in Fort Kochi Taluk Hospital. Then he was referred to GH in view of worsening thrombocytopenia. So initially, we managed him on OPD basis, but as his complaint of worsening lower limb pain and weakness, as it worsened, he was admitted under our unit on 28th for further evaluation. Then when we went into more detail, he said that there was a history of 2 similar episodes of acute muscle weakness over the past 2 years. And the last episode that had happened 6 months ago, which apparently resolved after getting IV fluids. These episodes were precipitated following vigorous labor. The patient also had no history of coronary artery disease, stroke, TIA, dyslipidemia, or any thyroid disorders. No surgical history, and he consumed mixed diet, and his sleep has been disturbed for the past few days. He also gives a history of right lower limb fracture 1 year ago, details of which are not available, and it was conservatively managed without any surgical intervention. The patient had a history of taking Ayurvedic medications intermittently for his illnesses, but currently at the time of admission, he was not taking anything regularly. His mother was a diabetic, no other significant history in the family. The patient was an alcoholic for 20 years. He drank around 36 units of alcohol per week, and recently stopped 2 years ago when his first episode of weakness had begun. He was an occasional smoker, no history of substance or IV drug abuse. So when he presented to us, his vitals on arrival, his blood pressure was slightly on the lower side of normal, and pulse was around 68. Other vitals were fairly stable. On general examination, he was alert, conscious and oriented, moderately built and nourished. Grade 2 clubbing was present in both the hands. Other examination was normal. Thyroid examination was also normal. So when we went into neurological examination, his cranial nerves were intact. His tone was decreased in bilateral lower limbs. And when it came to power, the lower limbs, hip flexors and extensors, knee flexors and extensors, and even ankle and foot movements were MRC 3 grade. His deep tendon reflexes were delayed. Plantars were flexor bilaterally. There were no signs of lower motor neuron lesion, and his coordination tests were normal. Romberg was normal, and when we made the patient walk, more of a waddling type of gait. And meningeal signs were negative. So we examined the musculoskeletal system also to rule out any neuromuscular pathology. And here on inspection, there was no skin lesions or any mucosal ulcers or thickened skin. No swelling or redness or rashes or scars at the joint site also. There was no obvious spinal deformity. On palpation, we couldn't find any local rise of temperature or swelling and tenderness in the upper and the lower limb joints. There was also no spinal tenderness. So when we assess the range of movements in the upper limbs, bilateral upper limbs were normal. In the lower limbs, we could not assess due to the underlying weakness that the patient presented with. Straight leg test could not be elicited to rule out any radiculopathy. The figure of 4 test was also negative, where we wanted to see if any issues in the sacroiliac joint was there. And the patellar tap test was also negative, ruling out any massive joint effusion in the knee. Other systems were fairly normal. We couldn't elicit anything significantly. So to summarize our findings from here, we had a 47-year-old male who presented with fever for 5 days and sudden onset symmetric weakness in lower limbs, predominantly affecting the lower limb flexors and extensors for 2 days. The weakness was associated primarily with difficulty standing and walking, but without any sensory deficits or bowel and bladder incontinence. He was recently diagnosed with dengue fever 1 week prior to the current presentation, and the patient has a history of 2 similar episodes happening previously over the past 2 years. On examination, the patient was alert, conscious and oriented with grade 2 clubbing in bilateral hands. Motor examination revealed proximal and distal muscle weakness in the lower limbs. Hypotonia was present in bilateral lower limbs. Reflexes were delayed in all limbs. Plantar responses were flexor. Coordination tests and Rombergs were normal. Other systems were normal. So at this point, we were primarily thinking of 1, Guillain-Barré syndrome, 2, post-viral myalgia, 3, acute toxic neuropathy due to a history of having Ayurvedic medications. So then we proceeded with our investigations. Sure, sir. Yes.
You should start from your history.
Yes,
What is the possibility?
yes, sir.
Before you go into examination, I think it looks like hypokalemia. This is what I feel from the history. You said 2 episodes, IV fluid correction. It looks like, I may be wrong. What I'm trying to say is, so try to get from the history. So what is your clinical diagnosis from the history? History should tell you what is the diagnosis. Then you said about the physical examination. But dengue, is it related to the dengue? Unlikely. Then diarrhea was there, So there was a diarrhea. So that probably is the reason for hypokalemia. Then he is alcoholic. That is for. Then you said thyroid is normal. So he has got polyuria. So is he a diabetic? These are all the questions you have to answer from your history. I'm sorry about it, That's what I feel. So I think this is what I felt about the case.
Okay, sir. He had the periodic episode of paralysis. Yes, sir.
Yes, sir. So next, considering these things, we also went ahead with the investigations. So our initial set of investigations had revealed the patient had anemia, patient had thrombocytopenia, along with the dengue NS was positive earlier. And when we came to the serum electrolytes, like Sir said, the potassium was 2 on admission. And following that, even the calcium and the phosphorus values in the serum was reduced. The creatinine was mildly elevated, 1.6 on admission, and vitamin D levels were also on the lower side. LFT was fairly normal, but there was an albumin globulin ratio of 0.83. The fasting lipid profile was normal, and TSH was also within the normal range. So next, we went ahead with the ABG of the patient. So the ABG had shown a non-anion gap metabolic acidosis. And then we went ahead and did a serum bicarbonate. So in serum bicarbonate levels on admission was 6. So following these set of investigations, then we concluded whether narrowed down the possibilities to either one, periodic hypokalemic paralysis, second being renal tubular acidosis, and third being multiple myeloma. So once the patient got admitted here with a diagnosis of hypokalemia induced weakness, so we started the patient on IV potassium correction, and careful monitoring of the potassium levels were also done. We also supplemented with magnesium, as the magnesium was on the lower end of normal. So we consulted with the nephrologist in our hospital, and following these discussions, we had sent urine sodium, urine potassium, urine phosphorus, urine chloride, and urine pH for further evaluation. So since there was also anemia in the patient, ESR was elevated with an AG reversal and a history of fracture 1 year ago, we decided to send serum protein electrophoresis also for the patient. Serially, we monitored potassium, and with our correction, the patient's muscle strength also improved and the potassium normalized. So then we went ahead to analyze our investigations further. So the urine routine was the first thing we did. So in the urine routine, the first there was glycosuria and also trace proteinuria. And the urine potassium initially on the first day was 11.6. The following day we repeated, it was 19.9. Urine sodium was also elevated, and urine chloride was on the lower side. So this gave a positive anion gap. And the urine pH was 5. So this was the serum protein electrophoresis result that we got, in which did not show any the M spike that we were looking for. So we ruled out multiple myeloma. And one more thing also we wanted to mention is the urine phosphorus was low here. So with these findings, what we concluded was the patient was diagnosed as a case of renal tubular acidosis. That with further evaluation, with what findings we had with glycosuria, a positive urine anion gap, hypokalemia with metabolic acidosis, and also only thing that did not come in was the urine phosphate being low. So that was the only finding that did not happen. With the urine pH also being less than 5.5, we made a provisional diagnosis of proximal RTA, type 2 RTA. The low phosphorus in the urine we thought could be explained by because the vitamin D of the patient was also low, so that could lead to low, and the serum phosphorus of the patient was also low along with the calcium. So hence maybe the urine phosphorus was also low. So discussing about this topic, so hypokalemia is a common electrolyte disorder that all of us have encountered, caused by potassium loss due to diarrhea, vomiting, and drug induced. So when it's mild, it can be asymptomatic and non-specific, like muscle weakness and fatigue. But if there's a severe deficiency, it can also lead to arrhythmias and death. So whenever we encounter hypokalemia, we should also rule out concurrent hypomagnesemia and correct for the same, because otherwise you'll be dealing with a refractory case of hypokalemia. So serum potassium levels less than 3.5 is hypokalemia, and severe is less than 2.5. So two mechanisms that I just wanted to also discuss was one is, we know that alkalosis can also is associated with hypokalemia, and hypomagnesemia is also associated with hypokalemia. Why? Because in alkalosis, the sodium potassium exchanger is generally activated more, which means the hydrogen ion from the cell goes out into the serum. So when that happens, there is increased intracellular sodium, which stimulates the sodium potassium ATPase channel that will draw the potassium into the cell. So this is the mechanism for causing hypokalemia. Second is the magnesium. So whenever the magnesium levels are adequate, they generally inhibit the channel called ROMK in the thick ascending loop of Henle. So this will prevent the potassium from going outside into the lumen. So when the magnesium levels are low, this inhibition is not happening, and hence the potassium is being lost into the lumen, and hence hypokalemia is happening. So the features of hypokalemia, like I said, could be neuromuscular, cardiovascular, the most dangerous being the cardiovascular causes, causing arrhythmias, palpitations, and leading to hypertension following that. Patient can also have constipation due to and paralytic ileus. So these are some of the most common symptoms that we encounter with hypokalemia. So when we talk about the ECG changes in hypokalemia, three main things that happen is, one is a flattening of T wave, which is not evident till the potassium comes below 2.5, but can start if it's reducing to less than 3 itself. Along with that, there's a prominent U wave, and also ST segment depression can also be seen in hypokalemia. So when it comes to treatment modalities, when it's 3 to 3.4, normally we use oral correction. So it can be a oral potassium chloride, or if there's also associated acidosis, we can use potassium bicarbonate also. But when it's less than 2.5, it's always an intravenous correction that we do go for. And if it's between 2.5 to 2.9, based on the patient's symptoms, we can decide whether to go for an IV correction or a oral correction. So this was just a summarize how to approach hypokalemia. So first thing is to always rule out pseudohypokalemia. So whenever the potassium values are high, it's better to ask for a repeat value, because when we store the samples for the long time, in case of any malignancies, the electrolytes can be released outside. So that will fall, because of the metabolism of the cells, the potassium can be taken inside. So that will falsely reduce the potassium value. So that's why we should rule out pseudohypokalemia. Second is history and physical examination. First is to see if there's reduced intake, because that can be the primary cause. And second is to rule out any transcellular shifts, like the common medications that we use, like insulin, beta agonists. These are some medications that is going to reduce the serum potassium levels. So whether to know whether this hypokalemia is renal or renal cause or extra renal cause, the next step would be to look at the urine potassium. So if the urine potassium is generally more than 15 millimoles per day, then it's more of a renal cause. If it's less than 15 millimoles per day, it's more of a extra renal cause. So when it becomes a renal cause, the next thing that we do is to do a TTKG value, which can be done, but might not be done routinely also, where we need the serum osmolality, the urine osmolality values too. So, and if this value is more than 4, then we know that there's a distal potassium secretion. So there is a renal loss of potassium. So what is the next parameter that we can use is the blood pressure. So if the blood pressure is high, then there is increased aldosterone activity. So when the aldosterone, one thing we have to rule out is increased aldosterone activity. So when increased aldosterone, the causes can be either because primarily the adrenal cortex is acting on its own, or the renin has increased and that's causing secondary increase in aldosterone. So what can be the causes for high renin is the renal artery stenosis, and also renin secreting tumors. These two things can cause increased renin and thereby increase the aldosterone secretion. But if the renin is low, then it's a primary hyperaldosteronism. Secondly, if the aldosterone is low, then it's probably we have to look at the cortisol. So if the cortisol is high, it's a Cushing syndrome that's causing this this issue. And if it's normal, then it's probably due to the automatic activation of the epithelial channels in the distal convoluted tubule, that is the Liddle syndrome. So if the BP is low or normal, then the next thing that we can use is the acid-base status. And if the acid-base status is showing more of metabolic acidosis, then our diagnosis fits in, that is renal tubular acidosis. But if it's more of an alkalotic picture, then we have to look at the urine chloride, whether to see the kidneys are excreting urine normally or not. So if the urine chloride excretion is adequate, then we proceed with the calcium and creatinine ratio. So this calcium creatinine ratio is basically to see whether there is to differentiate between two genetic syndromes, that is either it is Barter's or Gitelman syndrome. And if the urine chloride is less, it means that the less than 10, then it's more of an extrarenal cause. So this is the basic approach that we also tried following when we approach the case. And one more important thing that we have to keep in mind is the periodic hypokalemic paralysis. So this periodic paralysis can be of hypokalemia, due to hypokalemia, due to hyperkalemia, due to thyrotoxic stages also. The primary thing being there is a defect in the inherited defect in the calcium and the sodium ion channel. So this defect is what is causing the defective ion transport of potassium and thereby causing this hyperkalemia. So one simple approach that we followed here is, normally when we are encountering a normal anion gap metabolic acidosis, first thing would be to calculate the urine anion gap. So this urine anion gap, if it's negative, it will be more like an extrarenal loss of potassium. But if this urine anion gap is positive, extrarenal cause of acidosis. But if this urine anion gap is positive, then the next thing we look for is the potassium value, serum potassium values. So if this is increased, then it's more of an aldosterone hyperactivation that's causing the increased reabsorption of this thing. But if the serum potassium is negative, then if the serum potassium is decreased, then we have to look at the urine pH. Because generally in distal RTA, that is type 1 RTA, what happens is the H plus ions in the distal convoluted tubule, H plus K plus exchanger or the H plus ATPase exchanger, they secrete the hydrogen into the lumen. But if that is defective, the hydrogen ions are not getting secreted into the lumen, and the resulting urinary pH is alkaline. So that's what happens, and hence the pH is more than 6. But what happens in proximal RTA is contrary to what we think. Since there is more bicarbonate, the urine pH has to be alkaline. But it goes to an extent where the bicarbonate loss is so much that even the serum bicarbonate is less, and hence the amount being filtered is also less, and hence the resultant urine pH is more on the acidic side. So that is the reason urine pH helps us to differentiate between distal RTA and proximal RTA. So I would like to touch upon some other syndromic renal pathologies also, like based on which part of the nephron is affected. First one will be the Bartter syndrome. Bartter syndrome is more of metabolic alkalosis and hypokalemia associated together, and its primary defect is in the ascending limb of loop of Henry. And also next is Gitelman's. Here also Gitelman's is also another possible DD for hypokalemia and metabolic acidosis. But in all of this, the blood pressure is low or normal. So when it comes to Liddle's is the thing that's due to a defect in the collecting duct of the nephron, and here the blood pressure is going to be on the higher side. So that's how we can differentiate. So other than that, the Fanconi syndrome, which mostly affects the proximal convoluted tubule, is a cause for the proximal RTA, type 2 RTA, because it can happen when the patient is having a Fanconi syndrome. Proximal RTA is inevitably it's going to happen. So what is this Fanconi syndrome is what we'll be looking at next. Mostly causes can be genetic or it can be acquired also. Genetic causes is due to Wilson's disease, Dent's disease, cystinosis. These are some mutations that are going to cause this syndrome. But acquired is mainly due to drugs or heavy metals, like those which could be in the Ayurvedic medications that we are using, like mercury, lead. These are also causes of proximal RTA. So generally, if it's occurring in the childhood group, then we can say that the patient will present with growth failure, and this will be a prominent feature. But if it's happening in an adult due to acquired causes, then mostly history of fractures, then hypovolemia, so with symptoms of dizziness. These are the things the patient can present with. And one of the important causes of proximal RTA is also multiple myeloma. So that's why we wanted to work up for multiple myeloma also. So just a small revision of that. We know that the CRAB criteria is very important. Hypercalcemia, renal involvement with increased creatinine, anemia, and lytic bony lesions are the main things that help us distinguish multiple myeloma from MGUS, monoclonal gammopathy of unknown significance. So SPEP is what we do to serum protein electrophoresis is what we do to confirm the diagnosis. And also if we do a bone marrow study, and then if the plasma cytosis is more than 60%, that is also confirmative of multiple myeloma. And generally, one of the differential diagnoses that we encounter when we are dealing with multiple myeloma is it could be monoclonal gammopathy of unknown significance or a Waldenstrom macroglobulinemia. Only difference being in the SPEP, the type of antibody being elevated will be IgG in multiple myeloma, while in Waldenstrom it will be IgM. So the treatments are steroids, immunomodulators, monoclonal antibodies for multiple myeloma. So with this, I hope I've covered what our thought process was, and thank you for the opportunity.
Thank you, Chatur. Sir, storming academic work he had done. Okay. He had presented with a little bit clinical science slides at present. When he was presenting at first, he given only few slides of clinical symptoms only. Then he read and made it such an elaborate and proximal tubular acidosis, and about he had a discussion with our nephrologist, and he had made it well. And as sir said, he could have given a diagnosis of history of periodic paralysis. Okay. Guys can ask questions, anything that Chandra.
What is your plan, future plan?
So generally in
so what I'm trying to say, so what was the reason for the precipitation? So he tend to get it. So what is the advice you are given to this patient?
First thing is to avoid a carbohydrate rich diet, sir, because that can actually precipitate, and also and second is to avoid, he's a daily laborer, so one of the times this was precipitated when he went to Bangalore for his job. So maybe change his occupation, because heavy workload can also precipitate this, like heavy exercise or workload can precipitate this kind of an episode. So maybe a change in profession is what the next thing I'll advise. So dietary change, then like to take up more moderate activity than very severe physical load. So these two things I will advise, sir, mainly. So fracture, the calcium also was low for the patient when we checked. So one of the things is maybe the bone density is lesser, and vitamin D also was low. So that could have been the reason for the fracture. He was diagnosed with dengue, sir. So he is finished. So this actually could be an eyes. If we look at the history, he has been taking Ayurvedic medications. So that is one of the causes of acquired causes of Fanconi. So in that case, we were also thinking in the same lines. Ideally, if we see distal RTA is more likely to present in adults than proximal RTA. But this we actually thought of because all the parameters were fitting in, except for the phosphorus part in the urine. That is supposed to be high. But since the vitamin D was low and the serum phosphate levels itself was low, we thought the urine is going to be low anyway. So that's why we justified that part.
Any more questions, sir? Actually, to our casualty, many of the dyselectrolytemia is coming as hyponatremias. Many of the cases coming as this weakness, we are evaluating for neurological, sending for CT and all, after preliminary investigations. So this was a rare case. Actually, one more case of a lady is in our ward. She's discharged now. A case of hypokalemic periodic paralysis. It's becoming common cases, hypokalemic periodic paralysis. And we are evaluating the cause like proximal artery. Thank you.
Thank you for
Thank
the
you,
wonderful
respected members.